So hi, my name is Carrie. I'm one of the current Harvard Emergency Ultrasound Fellows in Boston at MGH and Brigham. Dr. Jon-Emile Stuart Kenny, who is co-founder and chief medical officer of Flosonics Ultrasound. Dr. Kenny received his medical degree from the University of Toronto, and he completed his residency and chief year in internal medicine at NYU. Dr. Kenny did his fellowship in pulmonary and critical care medicine at Stanford University in California. Dr. Kenny's talk at WinFocus 2024 is on Probeless ultrasound. So Dr. Kenny, can you tell me a little bit about this topic?
I can speak from as the co-founder chief medical officer of one of these startups. We're building a Probeless wearable Doppler ultrasound. And what I think is really neat about the idea of Probeless ultrasound in that it adheres to the body and can be worn over periods of time. I think that's what really kind of functionally fundamentally differentiates it from the traditional probe ultrasound. Even if it's a wireless probe, it requires a user to hold the device, maintain an angle of inclination, maintain a window, and that inherently limits kind of the temporal, so to speak, resolution of the data being captured, i.e. what I'm trying to say is it limits it to a very specific snapshot in time.
And so what do you think is the medium? Like you mentioned echo. Is that kind of what your company is working with, or what kind of patient population, what kind of modality are you thinking about?
Yeah, so that's the tricky part, as you could imagine. Our device, we kept it simple because, there's a lot of, I think, elegance and simplicity. And so our device is just a pretty straightforward 4 megahertz continuous wave Doppler that is meant to be, it adheres to the body. It gets, hours of data, and it just insunates essentially blood vessels. So the idea from our device is that it can be used really over any vessel, but what we focus on is the carotid and the jugular. And it sticks to the neck and it continuously insunates those two blood vessels. And the idea there is that by insunating the internal jugular vein, you're essentially getting kind of a continuous VEXA score, because you're getting, the S and the D waves and they reverse. And the physiology is exactly the same as venous congestion physiology. So we can continuously monitor that as kind of a window to the right heart, so to speak, down through the jugular. And then through the carotid vein, we pull out metrics as like a window to the left heart.
And for your Doppler ultrasound, is this something that patients are wearing like at night when they're sleeping, when they're not moving around too much, or like is it in conjunction with some kind of like telemed, like their cardiologist like is able to get this data over a prolonged period of time to determine whether or not they need extra diuresis? I'm assuming this is kind of the patient population you're working towards.
Yeah, we are phenomenal questions. Those are the patients that we're working towards. Right now, we're kind of focused on acute sepsis resuscitation, because there's kind of already an established physiology, an established value proposition for, say, using the carotid artery to determine if stroke volume is rising when you're giving fluids or not, and then sort of looking at venous congestion to see if the right heart is kind of filling up or not, excessively. And so our value prop right now is the device is put on patients. We've been on about 3,000 patients now, commercially. And so the device is applied predominantly by nurses early in sepsis care. So they're kind of screened. It's usually, the traditional severe sepsis, organ dysfunction, and you're thinking about bolusing this patient using the device in conjunction with a passive leg raise or a fluid challenge, and you're sort of seeing, okay, here's the heart at baseline, do a quick measurement, give a fluid challenge or do a Trendelenburg, and then look to see the right heart fill up through the jugular, look to see that the left heart's pumping it out through the carotid. All right, things are looking good. If they need more fluids, I can continue to help resuscitate in that way. So that's kind of our immediate beachhead commercial proposition. to your point, with time and with patience, what we really want to start doing is moving kind of out further out of the acute care setting into the more um, outpatient realm. And potentially, I think it's possible to start identifying structural heart disease through the vessels with big data.